Bye.
Welcome, everybody, to Knock Knock Eye with me, your host, Dr. Glockenflecken, your one-stop shop, your place to go for all things eyeball related. I do got some eyeball stuff today. I've got a handful of things, actually. It's an action-packed episode of Knock Knock Eye today. So we're going to start with an article that is like an area of, sometimes I'll come across things, parts of the healthcare system, things that are happening that are bad, that I'm like, why have I not thought of doing any content about this before? I read an article, we're going to talk about it, that is exactly that. It's like, oh, I got to do some videos. I got to get this information out there. So we're going to talk about it. That just is very recent. Today, I read this article. So we're going to do that. And then we will talk about a new Netflix documentary. I have not had a chance to see yet, but I have been asked about it. Multiple people have mentioned it to me. It's called Caterpillar. It's about eye color change surgery. So we'll get to that. And then if we have time, we will do a little mystery case of a Masquerade syndrome in ophthalmology that we see. All right. So let's start with this article by The Atlantic. Just wild article, devastating, awful. It's called "A Barbaric Problem in American Hospitals is Only Getting Bigger." And it is about ED boarding, emergency department boarding, which is the act of basically when you have to admit a patient to the hospital from the emergency department, but there is no place to put the patient. And so the patient has to be boarded in the emergency department, like room and board, except you don't have a hospital bed. You have a stretcher in the emergency department. You may be in the hallway. You may be in a room with like 6 other people, men and women. You may only have like a little like pull curtain to separate you from everybody else. You may be sharing a bathroom with like 10 other patients. That is what's happening with emergency department boarding. And so this article tells the story of a patient and it discusses this wider problem that's just getting worse and worse, which is these patients that need to be admitted to the hospital have nowhere to go. And so they are just staying and stacking up. You have so many people in the emergency department just waiting for beds for hours, days, just waiting. And this is part of something that has led to all the dysfunction in Peace Health Riverbend Hospital, by the way, that prompted the emergency physicians to start speaking out against administration. Not against administration, more just like, hey, can we do something about this? Can we make this better? And so that's what I'd like to talk about right now. Please go read that article. It's The Atlantic. Again, a barbaric problem in American hospitals is only getting bigger. Because this is just one of those topics. Like, I cannot believe I have not addressed this before. This is right up my alley as a content creator, as a physician. I look for these types of things. These things like that patients are seeing and are not, and may not understand the reasons why they happen. Like, it doesn't shock you to think that, patients who end up doing this and like not having a place to go are going to end up blaming the doctors. Be like, why have you not gotten me a hospital bed yet? Why am I still in the emergency department? Didn't you say I was getting admitted, 36 hours ago? What's going on? And so it makes sense from a patient perspective. Well, who's to blame for this? Of course, it's got to be the doctor, right? Because we're the face of healthcare. We're the point person. We're the person who's making the clinical decisions. Are we? I mean, that's the idea. That's what it should be. But this problem with ED boarding is, in my opinion, really squarely on the hospital administrators, which, by the way, some of them are physicians. A lot of them are physicians, and so physicians in general are not absolved of all blame for problems like this. But the physicians that are like in the thick of it, taking care of patients, doing their shifts in the emergency department, no, they are not to blame for this problem. It's the administrator. It's hospital administration in conjunction with insurance companies. I think the biggest problem here is ultimately, and I'm not an emergency physician, but I have talked to a lot of them, and I feel like I'm fairly well plugged into kind of these types of problems. Is that hospitals, in order to admit patients to the inpatient unit, you have to have enough staff to meet to staff those beds. So you may have beds that are open, but if you have no nurses and med techs and all the medical assistants, the requisite staff required to take care of those patients, you can't just leave someone in a bed. And so I think that's like a huge part of this. And the reason these patients have nowhere to go, they have to stay in the emergency department because hospitals, they have not met the demand. And demand for inpatient services has been increasing over the years because our population is aging. But this increased demand has not been met with the addition of more like more staffed beds. And why is that the case? Why do hospitals, why have they not, it's not like this is a surprising problem. We've known the population is aging. Why has administration not done anything about this? Well, it comes down to money. That's what it's always about with these types of things. Inpatient acute care admissions are it's an aging population. It's Medicare patients. And those types of admissions are often not profitable for the hospital. What is profitable for hospitals? Outpatient medicine, ambulatory surgery. You get your ophthalmologist, you get your ortho, you get your neurosurgeons, you get all of those folks in there doing the spine cases and joint replacements and retina and cataract surgeries. Like that's more profitable for for hospitals, and they outpatient services. All right. Those inpatient admissions that are all Medicare patients, Medicare does not pay well. I mean, it pays better hospitals than like independent docs out in private practice. And so, why would a hospital create more inpatient beds if that's not going to move the needle? And if anything, they might lose more money by having more inpatient hospital beds. I mean, they should, just because this is not how we should be making decisions for the community in medicine, is what's the most profitable thing, because you end up with situations like this where you don't have staff, you don't have enough beds, and the hospitals are going to want to take all the beds they have and make sure patients stay in them, all right, so that they don't have to do more admissions. And so the patients literally have nowhere to go. But this is like uh, a lack of resources of our own doing. There's no reason why administrators should not put the resources toward this unless they're just trying to like create as much profit as possible. And so this is squarely on the administrators, in my opinion. And it all comes down to money. And so how do we fix it? I mean, I don't honestly know. This is a little bit, now we're getting a bit outside my area of expertise. But what I do know is we need to change the incentives. Like, we should not incentivize these hospitals that, yeah, they're trying to run a business, but we should not incentivize them to not admit patients to the hospital. It doesn't make any sense. We should not incentivize them to leave as many patients as possible in the emergency department. And by the way, I think another reason they do this is because um, they don't want to, because how about this? Why can't these hospitals? Why can't they board patients like on the hospital inpatient floors? Like, there's no reason why these patients have to be just waiting in the emergency department. Why can't they wait on the fifth floor? Why can't they wait on the inpatient medicine floors? Well, probably because then you're going to make other people on other floors more unhappy. So from a hospital administrator standpoint, all right, well, hey, well, why don't I just, you know, just concentrate all the most unhappy people that might be inclined to leave negative patient satisfaction scores and negative reviews? Why don't we just concentrate that into one area of the hospital? So at least the people that have hospital beds, they can at least be a little happier because they're not crowded and not having to deal with, three other patients in their room. I I think that might be what they're thinking. I don't know. I honestly don't know. But the incentives are so messed up, and we need to incentivize the creation of more space for patients, and also the financial incentives to take care of them appropriately, and not just stack patients in the emergency department. Now, please, you guys, I'm kind of just I'm not an expert in this stuff. I'm not. Some of this is I'm just kind of guessing. I'm just kind of trying to look into the brains of hospital administrators, like might they be thinking. I think some of this is right, but if you have a different opinion here, like please let me know. Like I feel free to push back on this with me because I'm going to be doing some research into this topic as well. Probably should have done that before I started talking, but I think this is important, and it's where one place where we might have a disconnect between the public and healthcare professionals on like what is the reason behind the ED boarding issue. Oh, it's a mess, and I feel so bad for my emergency medicine, emergency physicians. It's such a hard job already, and you have like the weight of the healthcare system just just dropped right on top of them. They're trying to lift that up, and everybody's working against them. Even my fellow physicians, my fellow specialists who give them a hard time for like getting consulted. Like you read stuff like this article, it's like, how could you ever like give an emergency physician a hard time just for asking for help? It's we shouldn't be doing that. Their job is hard enough. And every year, it's getting more and more challenging, and we need them. Such an important part. It's almost to the point now where I think if we didn't have EMTALA law, which basically is what says if you show up to the emergency department, you have to be given care. You cannot be turned away, which is beautiful. It's a wonderful thing because it really kind of gets at the core of like the Hippocratic Oath and like what we in our soul like are thinking whenever we go into medicine. Like it's a very altruistic way of thinking, but I can't help but think that if that didn't exist, how many hospitals out there would shut down their emergency department the next day? It's like they don't even. It's like it's treated as a nuisance. It's like, oh, we have to do this. It's sickening the way we treat the emergency department and the people that work in it and the patients that are being seen there. And it's not at all on the physicians. Like, honest to God, they're working their asses off. So please read that article. Let me know what you think. All right, let's one thing real quick before we get to um actually I'll take a quick break, and then we may not have time for a case. I might save that for next week. But I do want to talk about this documentary on Netflix. Hey, Kristen.
Yeah.
You know how people probably know we love Cozy Earth?
Oh.
we're recording with a bed in the background and a cozy earth blanket nearby.
That is true.
Just in case.
Yep. I've got one in just about every room. I never want to be without them. They're so soft.
And you work from home, so you look really cozy most of the time.
Yeah. I love a good cozy lounge outfit. I cannot wear hard pants when I'm in my home.
So like the bamboo jogger set.
Exactly.
Those look great.
I can work and be comfy, and then I could also just pop out and run to the grocery store, pick up a kid from school.
And your feet. Yeah, I've been seeing you wearing the clogs.
Yeah, those are really comfy.
It's a cushioned footbed, the soft interior. It makes me want to work from home.
I know.
And now Cozy Earth gives you a 100-night sleep trial and a 10-year warranty on their products. This spring, give yourself the kind of comfort that lives with you all day, not just the moment you get home. Head to CozyEarth.com and use my code KNOCK for an exclusive 20% off. And if you see a post-purchase survey, mention that you heard about Cozy Earth right here on Knock Knock High. Comfort lives here. Hey, Kristen, remember how you love eyelid mites now?
Sure.
Well, there's a lot of confusion out there. I want to clear something up.
Okay.
All right. People think they can get eyelid mites from dogs and cats.
Can they?
No. These particular Demodex mites are specific to humans.
Okay.
So spread from dogs and cats is not expected. That's a myth.
Can't get them from cuddling our poodle.
No. Demodex mites that cause blepharitis live on humans. Most adults already have them. They just usually don't cause problems. It's when they overgrow that they can lead to itchy, red, irritated eyelids. Those little collarettes.
The crusties at the base of the eyelashes.
Right.
And the good news is there's a prescription eye drop available for Demodex blepharitis.
That is great news. To learn more about eyelid health and Demodex blepharitis, visit miteslovelids.com. Again, that's miteslovelids.com to learn more. This ad is brought to you by Tarsus Pharmaceuticals. Okay, new Netflix documentary dropped. It's called Caterpillar. Now, I haven't seen it, but I know the topic very well. It is eye color change surgery. So what I know is that this documentary follows David Taylor, a Miami man with insecurities about his appearance, who travels to India to undergo a surgery to permanently change his eye color from brown to green. I have thoughts. I have a lot of thoughts because eye color change surgery is something that I see on TikTok, and I see it specifically from one Beverly Hills ophthalmologist who's very prominent, massive following, much bigger than mine, who will show these before and after photos. It promotes all these cosmetic surgeries, including like eye whitening surgery, which is just he's just removing your conjunctiva, which I don't think that's great either. But he's also hawking this eye color change surgery. And so let's talk about this, because I think it's unethical, especially from a cosmetic standpoint. There are legit medical reasons why someone would need either an implanted iris or keratopigmentation, which is another way to give your eye a new color. So let's talk about these different options a little bit more in depth. So eye color change surgery is exactly what it sounds. You are doing a surgical procedure to change someone's eye color. Now, why does this exist in the first place? Well, this did not originate as a cosmetic procedure. This originated for people who were missing part of their iris, either from trauma or from diseases like aniridia, where they did not have an iris and were having significant light sensitivity, a ton of glare from any kind of bright light. Because if you don't, that's your iris, guess what? It's kind of important. You need it. It modulates the amount of light that comes into the eye. So if you don't have a normal iris, you're going to have all these side effects. You're going to be more light sensitive. And so a prosthetic iris is a way to try to fix that. And so that is the medical background for why it even exists in the first place. So there's two main ways that eye color change can work. So let's talk about the most potentially damaging one, which is the iris implants. So this is not a new thing. Like these things have been around for like 20 plus years. Again, designed for people who had like traumatic iris loss. And so you insert this little disc, a colored disc that mimics an iris. It looks like an iris. You just put it in the eye. It goes over the missing parts of the iris and can help cut down on glare and problems like that. The issue with this and what the why the outcomes have not been great and why even the American Academy of Ophthalmology is not too keen on people doing this is that the the implant, which is made of silicone, can damage the structures within the eye, leading to bleeding, leading to glaucoma, leading to cataract formation, and just basically other injuries to the eye that you don't want. And so, it's meant for people, a very specific population of people. It's not meant for cosmetic surgery for people who have brown eyes who want blue eyes. That's not the purpose of it. But you do have people that are doing that kind of surgery, and that was the subject of this Netflix documentary, apparently, which I'm gonna watch. Um, and is someone who had horrible complications from having one of these iris implants done. So don't ever do that. I would even be very wary of it, even for someone with an iris defect. I mean, it's more defensible to do it in that situation, but just the potential for complications is pretty high. So the other maybe a little bit less offensive, but still I think unethical in a cosmetic sense is keratopigmentation or eye tattoos. I've talked before about conjunctival tattoos, scleral tattoos, where people basically inject, tattoo artists. You'll go to a tattoo parlor to get eye surgery, and they inject ink in the subconjunctival space underneath your conjunctiva. Just Google eyeball tattoos. You'll see them. You'll see photos of them. They're very striking, and from an ophthalmologist standpoint, extremely horrifying. Well, keratopigmentation is taking ink and instead of injecting it somewhere else, like underneath the conjunctiva, you're injecting it into the cornea. Now, remember, the cornea is the clear front covering of your eye. It's clear for a reason. You need to see through it, folks. So, what people like this TikTok ophthalmologist from Beverly Hills, what he's doing is he's using a laser. And it always sounds fancier whenever you say laser. Oh, we use a laser. It's laser guided. All right. It's safer. It's better that way. And I can charge you quite a bit more for that. So a laser, you can also use a needle. Some people use needles, but a laser is used to create a little cleft in kind of not unlike a LASIK type of laser, to create a little space in the cornea and then where you can then insert pigment into that space you've created with the laser. And the idea is that the pattern of it overlaps with the iris. So no eye color change surgery is actually changing your eye color. You have the same eye color. Nobody can do that. And I hope to God that this ophthalmologist is informing patients of this fact. Okay, I've never talked to him, never interacted with him. All I've seen is uh, sales pitchy website. So not actually changing your eye color. Instead, it's just this layer of ink overlying the iris, filling in a part of your cornea. And this is meant to be permanent, by the way, because I mean you're messing with the cornea. Right? You don't, that's generally, even with LASIK, like you can see LASIK scars from the flap 30 years later. So when you when you mess with the cornea, this is an avascular structure. It's you got to consider it as permanent when you do something like this. And I can immediately see some downsides. Like, what could go wrong? Well, I mean, obviously this is surgery. You're injecting a foreign substance into the cornea, so you can get infected. Infection of the cornea is devastating. You can get uncontrolled inflammation. What if you react to this dye? You can get uveitis, inflammation inside the eye. The dye could erode through the cornea. It could leak out of your eye, and then you have a multicolored eye, as well as dealing with a cornea leak. Those are just a few of the potential complications there. Also, you have a fixed ring of dye in your cornea. What about when the iris, gets bigger and at night? But normally you want like a really nice big pupil when you're in the dark. But if you have this superficial ring of ink in your cornea, is that going to limit your nighttime vision a little bit? I would think so. I don't do the surgery, so I guess I wouldn't know. But just anatomically, that seems like it would be the case. It's just the benefits do not outweigh the risks, and I think if we're dealing with like I'm all for people like getting tattoos and it's their bodies. You can body uh you know uh, uh, modulation and the big earrings and piercings and what like all that's fine, but when you start messing with an organ, because that's what the eyes are, it's an organ. Like it's you have to, even with like body modifications, you have to weigh the benefits of doing something that you might feel like it's more you, like you feel like it makes you feel like more like yourself by doing this thing. You have to weigh that benefit with the potential risks, even with a run of the mill tattoo. All right. Maybe for that, the benefits far outweigh the risks. But with something like surgery on a mucous membrane and an organ like the eye, I do not see how the benefits outweigh the risks. And then it's up to the surgeon. All right. The patient can want it all they want, but the surgeon has to ultimately make that call. Are you going to are you going to do this surgery? Are you informing that patient enough about these risks? I don't care if they want it. Like you don't want to harm this person. What's the risk profile? All right. I do not think this is an okay thing to do cosmetically. Someone has a legit medical reason. They've lost part of their iris. They're having horrible glare and light sensitivity. Yeah. Okay. Do some keratopigmentation. That's a great thing to be able to give to someone. You're improving their life, but strictly cosmetic, got a big problem with that. So anyway, I all that to say, guys, don't get eye color change surgery. Your eyes are beautiful. Like the brown eyes, hazel eyes, green eyes, blue eyes, whatever. You got your natural eye is never going to get better than that. It's never going to. Look at the photos of people who have had this surgery. It doesn't, I'll just say it. It doesn't look great. It doesn't look natural. You don't have the natural striations of the iris that make it look normal. It does not look. If you're thinking like it's going to look natural, it doesn't look natural. Go look at the photos. And hmm, I just don't like the way that this doctor is pushing it. And he's the only one I see that's doing it. I don't know. There's probably other ones. There's probably some people in New York that are doing it as well, but we're in Beverly Hills and he's the ophthalmologist of the stars. So anyway, I'm excited to check out this documentary and get myself good and angry, which is, I'm sure, what's going to happen. Okay, so let's do one more thing real quick, and that is I talk about, I usually do like, I've been doing a thing I love, a thing I hate. Let's just stay on the hate train for a second. But this is more of I just don't like seeing this diagnosis. And I've only seen one. It's a sebaceous cell carcinoma. So we're not going to do like the whole mystery thing, but this is a masquerade diagnosis. We have some of these in ophthalmology. So herpes is like this, syphilis is like this, where it can look like a lot of different things. It can look like a benign condition sometimes, but turns out, oh, nope, you got syphilis. You got neurosyphilis. All right, it can be like that bad. So another one in the world of ophthalmology like this, a masquerade syndrome, is sebaceous cell carcinoma. Now, this is scary. So I'll just give you a quick rundown, like a typical presentation for something like this. You got like a 67-year-old who comes in with a bump right above the margin of the eyelid, right on the eyelid, has a bump. I get 3 of these a day. And usually it's a chalazion. So you look at the patient, and you see like a bump, you can kind of move it around. It feels kind of firm, but it's like it looks like a stye. And so, you do a quick exam. You see, there's a couple of the oil glands look pretty plugged up, the meibomian glands. Like, this is a stye. Do some hot compresses. All right, it'll get better. Patient comes back a couple months later, no improvement. If anything, it maybe is a little bit bigger, this little bump. It's like, okay, well, all right, let's, we tried, maybe at that point you give him a little steroid. Let's see, okay, well, sometimes with styes, you can throw a little topical steroid on the eye. It'll decrease the inflammation around these plugged up glands. And keep doing the compresses. It'll decompress. It'll get better. So maybe you do that. Maybe the patient's really nervous about having any kind of incision and drainage of a stye on their eye. Some people really don't like that. And so you try the steroid. All right, send them away. Come back a month later. It's even bigger. It's definitely not smaller. Maybe it's the same size, but could be a little bit bigger. All right, listen, it's time to do an incision and drainage. So you inject a little bit of the anesthetic, and you flip over under the eye, because whenever you drain one of these, you're making the incision on the underside of the eyelid. So you flip it over, you and you see this bump underneath the eyelid. And it doesn't quite look like a typical chalazion, but the chalazions, they can look like different things, but it has a little bit of pigmentation to it. It's kind of weird. It's very vascular, and you're not quite sure what to make of it. Not sure what you should honestly do with this thing. So you kind of cut into it, and there's no oil coming out of this thing. And so, you do the best you can, and sometimes draining a chalazion, it's not the most satisfying thing. Some of them are real satisfying. You make this little incision, and all that oil, just flows out, and that you can see the big bump in the eyelid, the swelling just disappear. It's great. I love that. This one's not like that though. So you do the best you can. You see, maybe you got a little drop of oil out, but really not much there. And then, hold some pressure. Tell the patient, continue the steroid, continue the hot compresses for another week, and come back if it doesn't get any better. Patient's back a couple months later. Doc, hasn't got any better. It's still, it's even bigger. It keeps getting bigger. What's going on? At this point, one thing that should be on your differential, if you have something that looks like a chalazion, looks like a stye, but it's just not behaving quite like a stye, you have to think about sebaceous cell carcinoma. So a sebaceous cell carcinoma is there. Sebaceous glands are found throughout the body, but you have a lot of them in the eye region. So sebaceous cell carcinoma is found most frequently around the eye. It accounts for about 75% of cases. About 20% of cases of sebaceous cell carcinoma are found in the parotid gland. All right, so you get parotid, a good amount of them there, but the eye, big hot spot for sebaceous gland, sebaceous cell carcinoma. And it's hard to diagnose. On average, patients are usually in their 6th or 7th decade when they get this. So older adults will get this. but also it can take on average 1 to 3 years to diagnose because we get fooled into thinking this is like a run-of-the-mill stye, blepharitis, just inflammatory disease that affects the space around the meibomian glands. And sometimes when you have a small sebaceous cell carcinoma, you actually also have a stye right next to it because that carcinoma is invading the meibomian gland and causing the gland to get plugged up. So you can still have a stye, but you also might have a sebaceous cell carcinoma. Now, fortunately, this is very rare. It's extremely uncommon. It accounts for about 0.2% of all eyelid tumors, which on their own are not very common. So it's extremely rare type of cancer to see. Like I said, I've only seen one, and that was a little bit easier to diagnose. It was a little bit further along by the time the patient got to me. So I knew like this looks like a cancer. To send him to my oculoplastics colleague who confirmed the diagnosis with an excisional biopsy. And so, yeah, some of the signs of it, we already talked about it. So it just something that looks like a stye, not behaving like a stye. You have it on your differential, but it's a carcinoma. So you can see things like loss of hair on the eyelid, loss of eyelashes. That's a weird way to say loss of loss of hair on the eyelids. No, eyelashes. So because as the cancer progresses, it's going to invade the hair follicles. It's going to invade the follicles of the eyelash and cause them to fall out. You'll lose them. So you get what's called matarosis. We also have a fancy term for everything. Loss of eyelashes in the area of the cancer. And then just an irregular eyelid margin, as it grows. And so if you're concerned about it, get a biopsy and then excisional surgery to remove it. With often you have to do a big reconstruction to put the eyelid back together when you take out a big chunk of the eyelid. There's also an interesting thing called, let's see if I can say this correctly, Muir-Torre syndrome. This is, I'm not an expert in this, but it's Muir-Torre, which is, I think that's what it is. So basically, it's people that you can get a sebaceous cell carcinoma in conjunction with GI malignancies, and colon cancer has been in the news lately. Rates of colon cancer are going up in young people, and so colon cancer and like GU cancers, urinary cancers, can be associated with sebaceous cell carcinomas. It's this syndrome called Muir-Torre syndrome, which is an inherited condition. And so often there's family history of this. You also have to worry about what's called pagetoid spread. So you can have not only the primary cancer in the eyelid, but you can get spread in patchy areas like on the conjunctiva. So often you'll do what's called, a map biopsies. You'll take little small biopsies of the conjunctiva in different places and make sure you don't see any signs of cancer in the near vicinity of the primary lesion. And that's all I'm going to bother you with about sebaceous cell carcinoma. It's kind of a scary one because it's so hard to diagnose, and that's not fair. It's not fair to anybody. It's not fair to me as the ophthalmologist, not fair to you as the patient. And so I hope you never have to speak of or hear from this disease again. That's it for Knock Knock Eye. Thank you so much for listening. And please send me an email, knockknockhi@human. That's Knock Knock Hi, by the way. knockknockhi@human-content.com with questions, concerns. If you have any concerns about like what I say, did I say something accurately today? Did I screw something up? Am I just not right about the ED boarding situation? Please let me know. Like, that's part of why I do this. I like having these conversations. I want to be educated as well. I do my best to be as accurate as possible, but please let me know if I get something wrong. You can also leave a comment on the YouTube channel @GlockenFleckens. Please go there. You don't even have to watch the video there if you want, but just come and leave a comment, or on wherever you listen to the podcast. All right, that kind of stuff really helps us grow this. I got a lot of great ophthalmology information in my brain. I'd love to get out to as many people as possible. So it really helps us whenever you do things like leave a comment on YouTube or post a review on Apple or Spotify or whatever it is. Really appreciate it. Thank you for that. My executive producers are Aaron Corney, Rob Goldman, and Shanti Brook. Editor, engineers Jason Portiz. Our music is by Omer Ben-Zvi. I am Dr. Galakam Plugin. Thank you so much again. We'll see you next week, everyone.
Knock, knock. Goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Hope you subscribe, leave a comment below. Let us know what you think.